This is week 2's lecture. We'll be covering diagnosis and classification of psychological problems. Quick note before we dive into the content of the lecture, I recorded these slides when I taught the class alongside a textbook, so there might be times when I reference a textbook or text, and you are obviously not responsible for any additional information outside of these slides. You're only responsible for the information that's contained within these slides. So there have been 3 proposed definitions of abnormal behavior. Actually, there have been many more proposed definitions, but they sort of lump into 3 groups, these 3 groups are the most common definitions. So the first is statistical infrequency or violation of social norms. The second is behavior that causes subjective distress, so distress on the part of the person enacting the behavior. And the third is behavior that causes disability, dysfunction, or impairment in the individual. For statistical infrequency or violation of norms, this suggests that because a behavior is rare, it is necessarily abnormal. And it kind of, the ideal model for this would be a normal curve where behaviors average behaviors. So most of you are probably familiar with a normal curve, but in case you're not, it's just a distribution of scores in the average population, in the normal population. And so scores that are closer to normal kind of fall under this hump. Most scores are going to be close to normal. And then on the left and the right side are these tails that represent the most extreme scores or the most rare or statistically infrequent scores. So a very common example would be IQ scores. IQ scores are fall into a normal curve, and so IQ score of 100, which is the average IQ score, would fall in that closer to normal on that hump of the normal curve. And really high IQ scores, so someone who is very intelligent and scores high on an IQ test, these scores would fall in the rightmost tail, that shaded area to the right. And very low IQ scores, so somebody who might have intellectual dysfunction, would fall in the leftmost tail. And these would be rare scores. That would be considered abnormal behavior under this definition. Advantages of this definition: cutoff points can be easily established and used. So a cutoff point for rare behavior could just be whatever falls in that shaded area. It kind of has an intuitive appeal to it as well. We tend to think we know abnormal behaviors when we see them. For example, if an individual is sitting at a bus stop talking to herself, we seem to think like that's relatively unusual. Maybe not so unusual depending on what part of town you're in, but we tend to because that behavior is relatively rare, we would consider it to be abnormal. Problems with this definition: it's difficult to choose what a cutoff point is. How do you decide where the cutoff point is? And I think most importantly, deviance from the norm is sometimes adaptive. So for example, going back to the IQ, the normative curve of IQ, extreme intelligence, which would fall in that rightmost tail, can be often an adaptive trait. Someone who is extremely intelligent is likely going to do well in life. As well, there's a big issue with cultural relativity in this definition. So what is considered a violation of a social norm or statistically infrequent varies based on the culture that somebody's in. So people in a minority group may be particularly susceptible to being labeled as abnormal, where they may actually be normal in their own culture or within a subculture. So for example, in South Africa, there's a tribe of people called the Zulu, and their traditional healers are Sangoma. And if a Zulu Sangoma was in the US and was behaving in a normal fashion for a Zulu Sangoma, they would be considered a statistical anomaly. They would be violating social norms. Zulu Sangomas vary in how they undergo their traditional healing, but they do engage in behaviors that are typically considered abnormal in the US. They have rituals such as like throwing bones to make predictions about somebody's life or to give guidance to somebody. Sometimes they'll speak in tongues. There's even a group of Sangomas, a relatively small group of Sangomas in KwaZulu-Natal, which is an area of eastern South Africa, where Sangomas will consume human flesh, which would be considered, I think, a pretty extreme violation of social norms within the US. In addition, Sangomas, the way that a Sangoma is chosen or identified within Zulu culture is that they go through a period, typically in late adolescence or early adulthood, a period of time where they have a lot of anxiety. They might even have psychosis, where they're seeing and hearing things that other people don't. They feel that they're speaking directly to God. And they also might have untreatable physical illnesses that all of these things which might be considered to be signs of a mental disorder in the US, whereas in areas where the Zulu Sangoma are more prevalent would be considered normative behavior. So you can see that this is a kind of more extreme example, but in general, I think cultural relativity is one of the biggest issues with this definition of abnormal behaviors. Abnormal behavior is also sometimes defined as behavior that causes subjective distress in the person exhibiting the behavior. Advantages to this definition is one advantage that it seems reasonable to expect that a person would be able to report or assess whether or not this person is experiencing distress. So a person comes into your office and they might be more able to clearly articulate, they would likely be able to clearly articulate whether or not they're distressed. Problems with this is that several disorders exist where a person may not feel subjective distress due to their own behavior. They might be creating a lot of distress in the people around them, but they are not personally feeling distress, at least in the moment, due to their behavior. So examples of this might include antisocial personality disorder, which is characterized by a person who might commit a lot of crimes, might do a lot of impulsive things and not really feel guilty about it, might hurt a lot of people around them. And in this case, they wouldn't necessarily feel subjective distress. They might be distressed by some of the consequences of their actions, but not by the behavior in itself. Another example is mania, which is a period of euphoria, maladaptive euphoria, where a person might do a lot of reckless things, spending a lot of money, engaging in risky behaviors. Typically, they don't sleep a lot. And often in mania, a person feels they feel good. They feel like nothing's wrong. They feel like things are going really well, but they're doing a lot of things that will have negative consequences further down the line. And then finally, often in psychosis, a person will have what we call like a lack of insight, meaning they might be experiencing things that the people around them find distressing. So they might be hearing things that don't exist, having visual hallucinations. They may have some strange beliefs that we would characterize as delusions, or beliefs that are tenaciously held but aren't real. And often people in the throes of psychosis don't realize that something is wrong, and so they may not be subjectively distressed by their symptoms. However, there are often negative consequences to this behavior. Another definition of abnormal behavior is behavior that causes disability, dysfunction, or impairment. Typically, this impairment or dysfunction would be in one or more of three areas. Social or interpersonal relationships are affected. In occupational impairment, the job is disrupted. They might be showing up late to work or not completing the work that they need to, perhaps even losing their job. And then personal impairment, and this is difficulty doing the day-to-day things that kind of keep a person's life working. So, for example, somebody with depression may find it difficult to shower frequently or to do their laundry so they're not wearing clean clothes. Advantages of this definition are that, again, relatively little inference is required. Dysfunction can typically be apparent or can seem more objective. So if someone has lost their job because of their depressive symptoms, that can seem like a pretty apparent interpretation of dysfunction due to psychological symptoms. As well, dysfunction is often the reason that people seek treatment because their normal life is interrupted. So again, with people with depression, often they've been feeling sad for a long time, feeling down, having difficulty getting through the day-to-day functioning of their lives, but they don't come to seek treatment until things get pretty bad, until maybe they're doing poorly in school or things aren't going well at work. Disadvantages of this definition, even though dysfunction seems like a more objective thing to define, how do you define it? What level of dysfunction is abnormal or impairing enough to be considered abnormal behavior? As well, some people are able to maintain functional lives and not show clear dysfunction despite significant distress. So in like functional depression, somebody's feeling down and depressed all the time, but somehow they're still able to maintain their job. They just push through the day. They're able to maintain some relationships. And so if we define abnormal behavior solely by dysfunction, these people would not be considered impaired, or they wouldn't be considered abnormal behavior. So what is abnormal behavior? I think it's pretty clear from the advantages and disadvantages of these three definitions that no one definition is sufficient, and all of them have utility in some situations, but no single one of them can stand alone as a definition of abnormal behavior. And so most classifications of abnormal behavior use a combination of two or more of these definitions. So for example, a schizophrenia diagnosis requires statistically infrequent behavior, so delusional beliefs, hallucinations, disorganized thought patterns, as well as functional impairment. If somebody with schizophrenia does not have functional impairment, they do not meet criteria for a diagnosis of schizophrenia. And I've had that before. I've had patients who come in because their family wants them to come in, and they are like seeing things and hearing things that aren't there, but they're able to maintain a job, they have a relationship, they're taking care of themselves, and so I wasn't able to diagnose this person with schizophrenia because they were living with it and functioning with these symptoms. Important to know as well, important to note that abnormal behavior doesn't necessarily indicate mental illness. So somebody can be behaving abnormally based on a situation, based on adherence to a subculture, or just they might be a strange person, and it doesn't necessarily mean that they're mentally ill. So what is a mental illness? It's a syndrome or a cluster of abnormal behaviors that is associated with distress, disability, or increased risk of future problems. And a mental disorder is considered to represent a dysfunction within the individual. Not all deviant behaviors or conflicts with society are signs of a mental disorder. So I always think back to like the punk movement and how this was considered like deviant behavior. People were spiking their hair and wearing safety pins on their clothes and things like that. And I think some people at the time would have considered that to be particularly problematic, but we certainly wouldn't call that a mental illness. It's just a simple deviation from the norm that might cause dysfunction in a society, might cause conflict in a society if people are not adhering to societal rules, but it's not about the individual. It's about how the individual interacts with society. And this is just another note that our book is not up to date regarding the DSM, and DSM-5 is the current version of the DSM, not the DSM-4 TR, as is mentioned in your book, just in case you didn't catch the intro slide. So what is the purpose of classification and diagnosis? Diagnosis is essentially a classification of psychological disorder based on symptoms and signs. Why give diagnoses? It's sort of the best strategy that we have to create a common language between clinicians. So if I have a client that I'm passing off to a psychiatrist, I want to be able to say, from my clinical judgment, this person suffers from social anxiety disorder and major depressive disorder. And the psychiatrist is going to be able to have a general sense of the types of issues that the client suffers from based on this common language that we have. It's kind of a shorthand. It's also an agreed upon definition or shorthand for human behavior that allows ongoing research. So if you want to study anorexia, for example, we need an agreed upon definition of anorexia so we know we're all studying the same thing. And this includes etiological research or research into the origins of disorders. And then finally, and kind of most practically, it helps inform which treatment might be optimal. The way that we do research on psychological disorders is kind of seeing if a certain treatment works for a certain group of people who meet diagnostic criteria for a certain disorder. At least that's the traditional way of doing clinical research. And if someone comes into my office that has depression, then I know, okay, I'm probably going to I'm going to consider these ranges of treatment that have been empirically shown or shown by research to be optimal for people with depression. The system that we use for making diagnoses and for classifying mental disorders in the US is the Diagnostic and Statistical Manual. This is what almost everyone uses. This is what insurance companies require a diagnosis from the DSM. And this is importantly determined by the American Psychiatric Association, not the American Psychological Association. And we might end up getting into that a little bit later, but just note that these are psychiatric diagnoses and are not determined by the psychological community necessarily. There's an international system called the International Classification of Diseases, or the ICD-10, which will soon be the ICD-11, and this is published by the World Health Organization and a lot of other countries, so European countries, I think some Asian countries, African countries tend to use the ICD-10. I think the only time that people internationally, as best as I can discern, the only time people internationally are using the DSM is if they want to do research and publish in American journals. The DSM, the first DSM, was published way back in 1952. And I say that ironically because that's actually not that long ago. We didn't necessarily have a standardized way of defining a lot of psychological disorders previous to 1952, which is actually not that long ago. The early DSMs, DSM 1 through 3, had some pretty horrendous issues of sexism, homophobia, transphobia, just a lot of biases that kind of reflected the general thinking of the time. So for example, there was a diagnosis called hysteria, which was just essentially a way of saying like, categorizing emotional women that were too emotional. Pretty much exclusively this diagnosis was given to women. Homosexuality, all the way through to the DSM-3, was considered a psychological disorder. Not being homosexual and being distressed by it, but just the simple fact of being attracted to the opposite sex was considered a mental disorder. And what was called transsexualism at the time, which would be encompass more like transgender identity or different kind of non-traditional gender identities, was also considered a mental disorder. Pretty kind of any sort of like cross-dressing or presenting as the opposite sex was considered a mental disorder. These are the main diagnostic categories of the DSM-5. I won't go through them, but you can look through if you're interested. The DSM-5 was published, I think, back in 2013, I want to say, maybe 2014. And I'm going to go over some of the highlights of DSM-5 changes because I think it reflects current changes in how the psychological and psychiatric community think about these disorders. So one of the changes was that what used to be called mental retardation is now called intellectual disability, in part because of the stigmatizing, the stigma associated with the term mental retardation. But importantly, severity of intellectual disability is now determined by level of functioning rather than IQ score. So it used to be anyone who scored below a 70 on an IQ test was considered disabled intellectually. And now it's IQ score is a piece of the puzzle, it's information, but this person also needs to have significant impairments in functioning, which I think is if I can insert my own opinion here, I think it's a great change. I've met many people who score relatively low on IQ tests, but are really able to function in society and function in their personal lives at what would be considered a normal level. Autism spectrum disorder underwent a somewhat controversial change. There used to be a range of disorders associated with autism. So there was autism, and then there was high functioning autism, and then there was something called Asperger's, which many people may be familiar with. It's kind of a higher functioning form of autism. But there wasn't really sufficient evidence to distinguish between high-functioning autism and Asperger's, and there was really research strongly suggested that all these these disorders associated with autism were really just a spectrum of severity within a broader umbrella term of autism. And so autism was put in a spectrum where you can have lower functioning or more mild autism, or lower functioning or more severe autism, or higher functioning, more mild autism. Schizophrenia changed. We no longer use subtypes in schizophrenia. So there are specifiers, which I might go into at a later chapter, but we no longer call people or say that people have paranoid schizophrenia or disorganized schizophrenia. We just say they have schizophrenia, and then sometimes they get a specifier afterward. Gender dysphoria, which is sort of the most updated version of gender identity disorder, or people who are transgender and experience distress from it. In this more recent conceptualization of gender dysphoria, it's emphasized that there's gender incongruence and distress, rather than just identifying as a different gender being a mental disorder. And it's still rather controversial because it's maybe not emphasized enough that the distress should be intrapersonal, should be distress that the individual is having about their gender incongruence, as opposed to distress over how the people in a person's life might be reacting to this gender incongruence. In substance-related and addictive disorders, so this would be like substance abuse, overuse of alcohol, etc., we no longer make a distinction between abuse and dependence. So we don't say if somebody's addicted to alcohol, we don't make a distinction between just abusing alcohol and being addicted to alcohol. Rather, it's rated dimensionally based on severity of the disorder. So you can have mild alcohol use disorder, or you can have moderate heroin use disorder, for example. Personality disorders, the criteria were not changed, but there was sort of a section 3, we call it, like an alternative approach to personality disorder diagnosis based on decades of personality research. And it's a dimensional approach, and I'll get into what that means a little bit more. But if you look at this picture, it's based on, if you look at the picture to the right, there's this list of personality trait facets. And so this is sort of researchers believe that these are all different ways that personality can be described in a person, and that in each of these personality facets, people vary. Like a high level of anxiousness, for example, could be dysfunctional, as well as a very low level of anxiousness could be dysfunctional. If somebody's not anxious about anything, they might be likely to engage in risky behaviors, for example. And so they answer in this alternative dimensional approach to diagnosing personality disorders. A person answers a very long list of questions. I think it's like 300 questions. And the clinician scores it and rates them on each of these personality facets. And I think this is an example of someone who took, some anonymous person who took the personality inventory for DSM-5, which is this tool that can be used to for this alternative approach. And you can see in red, I think these are scores that were a little bit higher than an average individual, or on the higher side. And then in yellow, these might have been like moderately high scores. And so it's just a different way of looking at personality dysfunction in a kind of more dimensional framework. I uploaded a copy of the personality inventory for DSM-5 in the optional resources section of the resources folder on LaLima, and you can take it, and there's a little scoring sheet at the end. Just, interpret it with caution. But if you're interested, you can answer 300 questions and see where you fall on these facets. So many of you might be familiar with the DSM, but in case you haven't seen it or are not terribly familiar with it, this is an example of how the DSM might write diagnostic criteria, or does write diagnostic criteria for bipolar 1 disorder. Criterion A, so a person must meet all these criteria. Criterion A is a distinct period of abnormally or persistently elevated, expansive or irritable mood, etc. I can let you read the rest, but it specifies how long it must last and how much of the day it might be present. So it's rather strictly defined. Criterion B is that during this period of mood disturbance, there have to be 3 or more of the following symptoms, and it specifies 4 if the mood is only irritable and not euphoric, and then it lists all these symptoms that we know are associated with mania. Criterion C, the mood disturbance has to be severe enough to cause marked impairment in some area of functioning. And criterion D, the mood episode has to be, can't be attributable to a substance. So it can't be that they use cocaine and had these mania-like symptoms. It has to be something that happened without some sort of outside influence. So, using these diagnostic criteria, how was abnormal behavior defined? And we can go back to our 3 sort of clusters of abnormal behavior definitions. There was an element of statistical infrequency or violation of norms. So one of the criteria, I think in criterion B, was that a person has to have inflated self-esteem or grandiosity. So what does that look like? This looks different in different societies. There are some societies where it's rather normal to be what we would call a bit grandiose, a little bit into yourself, and to express very high self-esteem. And there are some cultures where it's very unusual to express, to be boisterous or to express high self-esteem, like some East Asian cultures. And then there was a mention of engaging in sexual indiscretions, and the very word indiscretions means a violation of social norms. So what is a sexual indiscretion? Is sleeping with multiple people in a week a sexual indiscretion? It kind of depends on where you are. So there's certainly an element of statistical infrequency or violation of social norms in the definition of bipolar disorder. 2, behavior that causes subjective distress. In bipolar disorder, this is not actually included. So often, and I mentioned this before, often mania is not distressing during the actual episode of mania, at least not to the individual experiencing it. Sometimes it is, sometimes it's very distressing, but it isn't always, and so that's not an aspect of this particular disorder. And 3, there was certainly an element of disability, dysfunction, impairment. There was a specific criterion in which the mood symptoms have to cause impairment in social or occupational functioning. So what are some general issues in classification? There are plenty, and I will go through them one by one, but here's kind of a summary sheet. So categorical versus dimensional systems. A categorical system is when a system in which you must determine whether or not a disorder exists. So either you have anxiety or you do not have anxiety. Either you meet criteria for social anxiety disorder or you do not. And an example of this would be most of the disorders in the DSM, but also the current DSM-5 system of personality disorder diagnosis is a categorical system. So either you have borderline personality disorder, or you don't have it. In contrast, dimensional systems rank disordered behavior or mental illness on a continuous quantitative dimension. So on the degree to which a symptom or cluster symptom is present. So somebody can be anxious on a scale of 1 to 10, with 1 being not very anxious at all and 10 being extremely anxious. And you kind of, in a dimensional system, you get a little more information about exactly where that behavior lies in terms of severity. And an example of this is the personality inventory, this alternative system of diagnosis in Section 3 of the DSM-5, where people are rated on personality facets rather than going down the list of criteria to determine whether or not they have a disorder. In another example of a dimensional system would be if we wanted to rate anxiety, thoughts, emotions, and behaviors along a dimension. There are examples of kind of like normal thoughts, emotions, and behaviors, and then more severe. So this is kind of recognizing that even within a non-disordered population, there's a spectrum of experiences of anxiety. And then beyond severe would be like disordered behavior, where this is getting to the level that probably needs intervention. We kind of talked a little bit about advantages of dimensional versus categorical systems, but in general, dimensional systems just provide more information and probably better capture the nuance of an individual's functioning. Whereas categorical approaches are kind of easier. They're just more simple. So in research, for example, and with a lot of the statistical tests that we use, it's easier to just say if somebody has or does not have an anxiety disorder. As well, clinically, it's rather required that we decide if somebody has or does not have a disorder. If somebody doesn't meet criteria for a major mental illness, at least in with most insurance companies, you can't be reimbursed. So insurance will not cover somebody unless they have a categorically defined mental illness. Other considerations of classification systems are the bases and the pragmatics of that system. So different types of criteria are used often to diagnose different disorders. For example, if I want to make a diagnosis of antisocial personality disorder, I have to do an assessment of that person's behavioral functioning during childhood, because I need to establish that they had conduct disorder during their childhood in order to meet criteria for ASPD. Whereas if I'm making a diagnosis or if I'm considering a diagnosis of anorexia, I need to get my client to stand on a scale and determine whether their body weight is low enough to meet criteria for anorexia. And so these are two totally different arenas, two totally different types of assessments: a childhood history versus somebody's actual physical weight. So different criteria are sometimes used for different disorders. As well, the DSM classification system is decided by a committee of humans, meaning it is imperfect, and it represents something like the average clinical opinion, or at least the average clinical opinion of people who are powerful enough to be on the DSM committee. So for example, homosexuality, as I mentioned before, used to be classified as a mental disorder before the 4th edition of the DSM, because that at the time might have been the average clinician's opinion at that time in history, and I think that is it's fair to say that is no longer the average opinion. So unfortunately, any diagnostic system, the DSM diagnostic system at least, or any classification system, represents sort of what we know at the time and what we believe at the time, and is always going to be imperfect, especially in retrospect. Description and coverage. Description meaning, are the criteria sufficiently objective and clear? Are we describing the disorder well enough that a diagnosis can be made? And this is not always the case. It has not always been the case that criteria are clear enough. So for example, in the DSM-4 TR, criterion C for schizoaffective disorder, which is schizoaffective disorder is something like a cross between schizophrenia and bipolar disorder, or schizophrenia and depression. So criterion C was that delusions or hallucinations persist in the absence of prominent mood symptoms. And this was always a big issue for all of us schizophrenia researchers or people who worked with schizophrenia and mood disorders, because what is prominent? What does that mean? Like, nobody could ever decide what a prominent mood symptom was, and this led to kind of across the field low reliability in schizoaffective diagnoses. The wording has been improved in the DSM-5. It's a little bit better, but it's still a little challenging. In coverage is the question, do the existing diagnoses adequately cover the range of psychological problems that we see that actually exist in real life? And there are definitely different opinions on this. Some people say that too many psychological issues are covered and are considered disorders. These people say that we're over-pathologizing human behavior. So under the DSM-5 criteria, approximately 50% of people will have a diagnosable mental disorder at some point in their lives. And some people, this is at least an estimate, this is somebody's estimate. As a side note, I think it's worth considering, is this a problem? Is it a problem that the average person, or at least half of the population, would have a diagnosable mental disorder at some point in their lives? Almost all people have diagnosable medical illness in some point in their lives, and I wonder if the hesitation comes a little bit in part from a stigma against mental disorders. But it's certainly up for debate. In other cases, some people with impairment and psychological distress are not included in the DSM. So again, I'm going to give you a psychosis example because that's my wheelhouse. But for example, there's something called attenuated psychosis syndrome, which is not a DSM diagnosis, but it's something that's been proposed to be added to the next, like the DSM-6. And this is something that some people, so that we know that there are people in the world who have psychosis and have functional impairment, but they don't meet full criteria for schizophrenia or any other psychotic disorders. And so because these people don't get a diagnosis, they also are not able to get treatment. And this can often turn into full-blown schizophrenia. So there's kind of a period before the onset of schizophrenia where people are experiencing these like attenuated or lessened symptoms of psychosis, and we know that if we're able to intervene at this time, we can improve the outcome of the disorder. But because we can't diagnose it, because it's not in the DSM, often we can't bill for it, and we can't always provide people with the appropriate treatment. Reliability and validity are always extremely important in any classification system. There's a lot to be said about reliability and validity when it comes to especially the DSM and making diagnoses, but I've chosen one type of reliability and one type of validity to talk about. Inter-rater reliability is the extent to which different clinicians agree on a diagnosis. So if a client comes into my office and I assess them, will I come up with the same diagnosis as if the client had gone into my colleague's office and undergone an assessment? One way that the diagnostic process can be more reliable is by using structured interviews, which is just what it sounds like. It's a set of questions that comprise an interview that you kind of just read off the interview, and if everyone's asking the same questions, then it's more likely that people are going to come to the same conclusions regarding diagnosis. There is one based off of the DSM, which is called the SCID, and the SCID-5 is based off the DSM-5. People honestly don't really use this in a clinical setting. This is more for research, and the SCID is super long. It's like, oh man, it's like some versions of the SCID are almost an inch thick, like a paper. Other versions are like maybe a little bit shorter. There are briefer versions that are maybe like half an inch thick. So we just don't have time in a normal clinical setting to do that. So it really isn't super common to use structured interviews, and this does lead to reliability issues in a real life clinical setting. This is an example of the SCID. This is a portion where you would be assessing for a current manic episode. So if somebody might have bipolar disorder, you would ask in the past month, has there been a period of time where you're feeling so good, high, excited, or on top of the world that other people thought you were your normal self? And you might remember the criteria for bipolar disorder that we discussed a little bit earlier, and this kind of hits on criterion A of bipolar disorder. And I think most of you are going to be too young to remember this, but there used to be like, I call it like a choose your own adventure interview. So there used to be these books that were like choose your own adventure, and you like read a section and then you decide if so maybe you read like a section where like the kids are going on an adventure, and you decide at the end, like, will they go to the river or go to the mountain, something like that. And the interview is like this. So if they have been experiencing a period of excitement, unusual excitement in the past month, then you ask what it's been like. So you have this additional query. Is it more than just feeling good? And then it has a recommendation for other things you could ask. And if not, then you have this other query. Have you had a period of time where you're feeling irritable, angry, etc.? And if they answer yes to one of these, you circle the little plus sign, and you move on to criterion B of mania. And if they say no to both of these, then you move on to another section, A54, and you assess for past manic episodes. So it's a lot of flipping through pages, but it does lead to more reliable assessment. And moving on to validity, one type of validity that's particularly important in a clinical scenario is predictive validity, which is the extent to which a diagnosis is able to predict future outcome, treatment effectiveness, etc., of a person's mental health concerns. So, for example, I would hope that giving somebody a diagnosis of social anxiety disorder would help to predict how a person might function in the future, which treatments would be best suited to address their concerns, if we have to worry about anything else, like if we should keep an eye open for depression, which is often the case in social anxiety disorder. So it's important that diagnoses have high predictive validity so that they're able to give us meaningful information about that person's clinical presentation. Bias is certainly a big concern in classification systems. So bias, concerns of bias are whether diagnostic categories of the DSM are biased against certain people. And as well are some clinicians systematically biased against certain people. I deviate from the authors of our book a bit here. So I felt that Trull and Prinstein didn't feel that our diagnostic categories or that the DSM system in general was biased against certain people, or that clinicians are systematically or commonly biased against certain people. I believe that, of course, this is the clinical experiences, clinical settings are in the real world. Clinicians are real people, and we go through a lot of training to try to examine and combat our own biases. But they exist, and I think we have to acknowledge this. And as well, I think there are systematic issues within society that are unfortunately reflected as well in the clinical community. So for example, I talked a bit about gender dysphoria earlier. Gender dysphoria is often diagnosed in transgender individuals who experience distress not because of their own discomfort with their gender identity, but because people are bullying them. And so there's the question of, are we calling a person disordered when really it's the society that they live in that's disordered? As well, we know from research that schizophrenia is diagnosed way more often in people who are Black or African American, and also diagnosed more often in immigrant racial minority groups. And some of this may be explained by, in general, like a more disadvantaged status of people who are Black. There's the stress of racial discrimination and kind of like systematic oppression. But there's also indication, studies have tried to parse this out, and there's indication that when a person with schizophrenia and a person, when a person who is Black and a person who is white present with the same symptoms and express those symptoms in the same way, the person who is Black is more likely to be diagnosed with schizophrenia. And I think as clinicians, we have to take that seriously. As well, women, there's indication that women there may be some biases against women within diagnostic categories, and also in clinicians in general may be biased against women. So women are more likely to be given a somatoform disorder diagnosis for unexplained illness. So somatoform disorders are generally disorders where somebody believes that they have an illness, but the cause of this belief and the physical distress, subjective physical distress, is actually due to psychological troubles. And so research has been done where kind of vignettes or little like scenarios are given to clinicians where two patients will come in with the same complaints, and one patient is a man and the other patient is a woman, and way more likely clinicians diagnose the woman with somatoform disorder. As well, pain, which is considered a psychological issue as well, not because pain isn't real, but because many of the mechanisms for dealing with pain and for some of the treatments against pain are psychological interventions. Pain is taken less seriously, particularly in people of color and particularly in women of color. So we have empirical evidence that there are biases, that there are systematic biases, and that I think it's more subjective whether DSM is biased against certain people, but we do know that there is bias in the system, and we have to acknowledge this. So that's my opinion, and I hope that it's based in fact. But more importantly, what do you think? Here are the diagnostic criteria for gender dysphoria. What do you think? Do you think that this is an appropriate disorder to have in our statistical manual, or do you think that it should be rephrased? A few miscellaneous additional criticisms or issues that come up with classification systems. There's often stigma against people who are diagnosed with a mental illness, and so as clinicians and as a field in general, we have to be aware that labeling someone with a mental illness diagnosis can be impactful in a way that is not helpful at times. As well, the categories we have don't capture the uniqueness of a person. So a disorder doesn't define a person. For example, a lot of my pet peeve is the term schizophrenic. There's no such thing as a schizophrenic. There's a person with schizophrenia, but schizophrenia does not define the person. And this is a major complaint of patients in general when it comes to their care in behavioral health settings and psychological treatment, is that often people feel like they're being treated like just like a cluster of symptoms and being treated as like a diseased person, where really we should be looking at the whole person, looking at their strengths, looking at some things that aren't working so well for them, and treating the person as a whole. The DSM-5 has attempted to increase its awareness of ethnic and cultural considerations and its treatment of these considerations. So in mental illness in general, culture can influence many things. It can influence risk factors. Some people in different cultural groups may have greater risk factors, depending on how, like, family systems, and yeah, just a range of factors can influence this. Types of symptoms that a person experiences can be influenced by culture. Kind of a typical or a common example of this is that some people in some East Asian cultures might experience or conceptualize anxiety as more somatic. So, whereas in the U.S. we might, in mainland mainstream culture in the U.S., we might describe anxiety as like, I'm feeling jittery, I'm feeling nervous. We might even use the word anxiety. Somebody from certain regions of East Asia might be more likely to describe sort of the same issues as I have a stomach ache, I feel very tired, I don't want to do anything. And even though these are both types of anxiety, they're described differently and maybe even experienced differently. As well, there's certainly a difference in willingness to seek help, mostly based on differences in stigmatizing views toward mental illness. And finally, availability of treatments can vary between cultural groups. There are certain cultural groups or religious groups, for example, who don't believe in the use of psychiatric medications. In this case, psychotropic medication or pharmacotherapy might not be available, or might not be feasible for someone who's a member of this religious group. And so you might need to focus on like psychotherapy options. So things that the DSM has done to try to increase their consideration of cultural and ethnic factors is, in general, there is more mention throughout the text of the DSM of just, take culture into consideration, take somebody's background into consideration. There's a cultural formation interview, which is a semi-structured interview that it's recommended could be done at the beginning of like an assessment, a diagnostic assessment, in which the individual is kind of asked open-ended questions about how they identify culturally and how that cultural or ethnic identification sort of affects their life and their views. As well, there are explicit definitions and examples of culture-bound syndromes. In one of the, I think, anxiety sections, this culture-bound syndrome of Koro is described, and Koro is like a intense or pervasive fear that genitalia are attracting into one's body, which I think in mainstream US could seem rather unusual, but it's a syndrome that's common enough in people from some regions of Southeast Asia that it has its own name. And so it might sound kind of silly to a mainstream US person, but it is based in sort of historical beliefs, medical beliefs. There's a belief that this can happen and that this can lead to death. So this is explicitly mentioned in the DSM, making clinicians more aware of something like this. And if you're interested, there are more examples on this Wikipedia page. And in general, there are these guidelines as well to help clinicians take cultural considerations into account. And I won't read through them all, but it is worth a look over. Okay, so the last section of this chapter is causes of abnormal, kind of models for causes of abnormal behavior and mental illness. The major models of psychopathology are listed here. There's a kind of a better slide. A more general model as well, another more general model is called the diathesis stress model. And this, yeah, it's more like overarching, it's more of an umbrella model. But diathesis is a predisposition or vulnerability. So for example, genetics would be a diathesis. And stress is any external or environmental factors. So exposure to lead during childhood or poor nutrition or a dysfunctional family environment. And in the diathesis stress model, the combination of this predisposition and the external stressors can produce psychological problems. Importantly, the diathesis and stress can interact and kind of, it could be a cyclical sort of situation. So a person who is genetically predisposed to be anxious, which is the diathesis, the genetic predisposition, might avoid social situations, causing them to have fewer friends, making them more likely to have less social support, and then therefore creating a higher level of stress in their life. So in this way, the diathesis has kind of caused the stress, and then the stress is interacting with the diathesis to create possibly social anxiety disorder or an anxiety disorder.